The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. This morning I wanted to go over a podcast on balloon pump pearls. Just recently helped out the clinical team at Air Methods with some balloon pump competencies, and I thought, what a perfect podcast to just go over the pearls of transport. So I'm going to list kind of my top 5 first things that I want to evaluate and look at before we actually transfer our patient to our helicopter. And then I want to really focus on what's the difference between a mechanical versus a chemical balloon. I think that's often a concept that we forget about, and I think if you don't have a lot of experience with balloon pump therapy, if you're new to this, you're new to the critical care environment, just coming in, maybe you've just joined a base that transports balloon pumps, this may be a concept that's kind of foreign, and I think it's very easy to, number one, get overwhelmed with the balloon pump part, and then we have to then combine our knowledge and understanding of how are the medications that the patient's currently being given, how are those medications applying to the therapy? Are they hindering the therapy? Are they maybe not allowing full therapy? Or could we maybe increase the chemical balloon to help augment the mechanical balloon? So I think that comes with experience, and that comes with understanding, number one, your medications, understanding the numbers you're seeing on your balloon pump. So let's go through the top 5 things that I'd look at based on what I've been taught in my experience with transporting balloon pumps. I think we would all agree, even if you're at a busier balloon pump base, you may only see a base do, and I'm just throwing a number out there based on my experience, maybe 25 a year. You know, if you're working at a base where you're doing a lot more than that, I think that's not the norm. But 25 a year, and then when you look at 25 a year, how many are you doing personally? You may only do 2 or 3, right? You've got to spread the wealth. Maybe you're one of those that has the black cloud, and you get all of the balloon pump transports. My point is that we have to understand this is a low volume type of transport. It's not something that we become very good at, and I think the best providers out there that have really done a lot of balloon pump stuff are probably the nurses that have come out of a cardiac ICU where they've managed these balloon pumps for days on end and seen these patients through from the start of their therapy all the way through the weaning phase. So I think if you have that person at your base, you have that person that you have access to, that's where you really have to pick their brain, ask them questions. And I think I've been very fortunate to have those people in my life. Kelly Miller, we had him on the podcast last year and did a great podcast on kind of everything that we need to know about balloon pump transport. Another nurse that I've really picked his brain on is Chris Lockard. And so, obviously there's a lot of people out there that are really versed in balloon pump transport, balloon pump therapy, understanding how all of this applies to our medication side. So let's get into our top 5. The first thing I do when I walk in to a balloon pump transfer is I want to know, number one, the balloon size. The balloon size is very important, and I think when you look back at maybe 5 years ago, for example, and I'm just throwing a number out there, it could have been, 3 years ago, it could have been a little longer. I think it was very, very common to see most adult patients having a 40 mil balloon. And now we're seeing cardiologists using these mega balloons, these massive balloons, or what are called 50 mil balloons. where you would only see those in, guys like Shaquille O'Neal, for example. And again, I'm just joking, but you had these big, massive balloons, and those were only reserved for these larger, taller patients, and these were based on obviously height. And now you're seeing these bigger balloons. So why do I want to know? Well, number one, you have to know the size of balloon for a few reasons. If you're using a McKay or a product like the CardioSafe Hybrid, the CS300, things like that, it's very important to, number one, know the balloon, because if you do have a console failure, if your balloon pump fails, dies, it crashes, whatever happens, to where now you're left to autofill that balloon. And we autofill the balloon if the balloon is not moving for 30 minutes. Once you hit that 30 minutes, then you're going to auto-inflate that balloon every 5 minutes until you arrive at a facility. If you're transporting the patient and you're 15 minutes out from a facility, there's really no need to autofill that balloon. But the reason why we want to know the size is that in a McKay balloon pump, you're supposed to use 10 mils less than your balloon pump balloon size. So if that balloon size, if the cardiologist says, hey, we've put a 50 mil balloon in, you're going to inflate that during an auto failure, again, based on the guidelines I had just stated, every 5 minutes, and you're going to use 10 mils less than what that balloon size is. So we would use 40 mils. So that's where I want to know the size. If you're using an Aero product, the Aero product actually tells you, the balloon pump actually tells you how much to fill the balloon. So, but I think it's a good habit to get into. Know what size balloon has been placed in your patient. Another reason why you should know the size is if they're putting in these mega balloons, we only have so much kind of area for error. And that balloon sits 1 to 2 centimeters below the left subclavian, and it sits 1 to 2 centimeters right above the renal arteries. The bigger the balloon, the less margin of error. And so we have to just, again, have that higher index of suspicion, make sure we're checking our patient maybe more often. Just be more thorough in your assessments, checking left radial pulses, making sure your urine output stays consistent with what was happening prior to your arrival. Number two, I want to know if the patient is balloon dependent. Why? I think anytime you're moving your patients, if we're talking about simple airway management, you've heard me hound on this over and over and over. It's always safest to maybe remove the BVM, remove the vent circuit. And you do that just for a short few seconds to take the patient in and out of the helicopter, in and out of an ambulance. Tube dislodgement happens during movement in and out of an ambulance or a helicopter or from bed to bed. That's when that dislodgement happens most often. So I've just found it's easier to just disconnect your machine, disconnect whatever tool you're using. Nobody touched the ET tube. Well, it's no different with a balloon pump. It's always best if you can to put that console in standby, disconnect the tubing, move your patient over, right? It takes just a few seconds. Move the balloon pump into whatever transport device you're using, whether that's a helicopter or ambulance, and then plug your balloon pump back in and hit auto start. If they're balloon pump dependent, what that means is that they're going to go into an arrhythmia. They're going to show clinical signs of decompensation if you put the balloon pump console in standby. So I want to know that. I want to know that before I try that. If they're balloon pump dependent, then I'm not going to obviously do that, and we're going to have to be super, super careful when we load and unload the patient. Number three, I want to know my confirmation for placement. So wherever you pick the patient up, most often we pick our patients up out of a cath lab. You should have a chest x-ray visible to you, and you want to confirm that distal tip of that balloon pump balloon is right at that second, third intercostal space. That correlates with, as I said, 1 to 2 centimeters below the left subclavian bifurcation off that aortic arch, and then 1 to 2 centimeters right above that renal artery. So confirmation. Number two, I'm going to check for my radial pulses. I always check both arms at the same time. I want to make sure I have equal pulses. And I always get in the habit of I've always checked my pedal pulses as well. Again, just a good assessment rule. Ask about urine output. Make sure every balloon pump patient has a Foley catheter. How much urine output have they had in the last hour? Make sure you see that that's consistent through your transport. Number 4, protection. What do I mean by that? As we've talked about with airway management, with RSI, it's always good to place every patient in a C-collar. And it's simply just to help prevent any head movement, excessive head movement side to side, so you don't have potential tube dislodgement or movement. With a balloon pump patient, it's always a good idea to put a knee immobilizer on the patient. Whatever leg, whatever femoral artery that catheter has been placed through, place that leg immobilizer on that leg. Have the balloon pump tubing going down towards the knee, and that will help you prevent any dislodgement, any movement of that catheter. And number 5, and where we're going to really focus on this podcast, is evaluate your pressures. Kind of get a good baseline, right? Look at your unassisted systolic versus your assisted systolic. Look at your diastolic augmentation. Look at your diastolic dip and evaluate your mean, or what would be the MAP pressure. Understand the medications you have going, right? We're going to focus on kind of the big 4 that you see most often. We're going to look at dobutamine. We're going to look at milrinone. We're going to look at Neo and Levophed. So let's dive into our pressures. The first pressure we always want to look at and identify is, what is your unassisted systolic and your unassisted end diastolic pressure, or aortic end diastolic pressure. So that's always going to be the Artline waveform that is prior to an augmented waveform. So prior to balloon firing, the waveform is always going to be, prior to that unassisted systolic and unassisted aortic and diastolic pressure. So we want to evaluate that, get a good baseline. So for example, let's say our unassisted systolic is 120 and our unassisted aortic and diastolic is 80. Our next waveform, we should have diastolic augmentation. That balloon should fire directly off of that dicrotic notch. That dicrotic notch indicates aortic valve closure. That means that the systolic phase has stopped. The diastolic phase has started. We have full diastolic augmentation. That is now your high pressure. So that's always something you document, right? That is what we kind of consider now as your true systolic blood pressure. Because out of any phase now, whether we're talking about your assisted systolic or your assisted aortic and diastolic pressure, or we're talking about your diastolic augmentation, that is now truly your highest pressure throughout every phase of the cardiac cycle. So we can kind of look at that as, now that is our true systolic blood pressure. But that's happening during diastole, and that's allowing for really, really good perfusion to those coronary arteries if timing is correct. So our unassisted systolic, unassisted aortic and diastolic, we have balloon firing off a dicrotic notch. We have what's called diastolic augmentation. That diastolic augmentation really should be at least 10 points higher. That's kind of a good goal to achieve, 10 points higher than your what your unassisted systolic would have been. And then our waveform after that augmented beat is now considered your assisted systolic and assisted aortic and diastolic. And what you want to see there is you want to see a drop. Now we have to remember, when that balloon actually deflates, that causes a suction effect. And essentially it allows that left ventricle to contract during the next systolic phase under a lower pressure. So we're reducing afterload. So that's the whole point of balloon pump therapy, is we want to reduce our afterload We want to augment our diastolic phase with a higher pressure that allows for better coronary perfusion. And again, when that deflation happens, that causes that kind of suction effect, optimizes forward flow, allows that left ventricle to contract under a lower pressure, right? We have to remember that left ventricle is diseased, it's sick, it's injured, it needs help. So what we want to see is we want to see a reduction. Every balloon pump console, you can add kind of that isometric line. You can raise and lower that. And a great thing to do is put that isometric line on your unassisted systolic, and you should see a pretty good reduction. And again, we want to see a reduction of anywhere from 5 to 10 points, millimeters of mercury. So if our unassisted systolic was 120, we would want to see our assisted systolic 5 to 10 points lower than what that unassisted systolic would have been. What about the diastolic? As we said, we have our unassisted aortic end diastolic pressure. It was 80. And one of the most important, if not the most important, number to look at is what's called our diastolic dip. And the diastolic dip really shows you the reduction in afterload, the reduction in how hard that left ventricle is having to work. If we can see a reduction in our diastolic pressures, our heart is better off. So the bigger the drop from that unassisted aortic end diastolic pressure to now the assisted aortic end diastolic pressure, the better we are. If you see 10 points, that's great. If you see 20 to 30 points, that's even better. The bigger the drop, the better off your patient is. So as I said, we look at our unassisted versus assisted systolic. We look at the same thing based on unassisted and assisted end aortic diastolic pressures. We want to see that reduction. We look at our diastolic augmentation. As I said, that's now your highest pressure. That's where your coronary arteries are perfused. And the last thing we look at is we look at what's called the mean. And now when we look at medications and we're applying our pharmacology, this is where we get into mechanical versus chemical balloon. If I said, hey, our diastolic augmentation pressure is 170, I think we would all agree if I said previous that is truly now the high pressure that your heart is seeing. So you could look at that and say, well, that's kind of like my systolic blood pressure. We wouldn't want our systolic blood pressure to be 170, 180. Well, a balloon pump patient is the same thing. Let's think about what happens in these patients that need balloon pump therapy. They have a left ventricular dysfunction. Most often, these left ventricular dysfunctions are related to long-standing hypertension, but you can have a cardiomyopathy, gestational cardiomyopathy based on a mom that has delivered. You can have an apical ballooning syndrome. You can have a left ventricle that is now infarcted based on a big anterior wall MI. So there's lots of reasons, but for whatever reason, your left ventricle is not working. And a lot of these patients will have a big overload situation. And so if they have an overload situation, you have backup of fluid that has pushed up through the mitral valve into the pulmonary circuit. So you have edema, you have pulmonary vasoconstriction, you have CHF, and you have an increased systemic vascular resistance. Well, that left ventricle has to contract against all that pressure. So the whole point is we want to reduce that systemic vascular resistance. We want to allow for a lower pressure so that left ventricle can actually contract more effectively and more efficiently. So if we go back and we say, hey, this patient's got a diastolic augmentation of 170, well, that's not good. We don't want that. What if that same patient has a mean of 140, right? Do we need a MAP blood pressure of 140? No, we don't. So that's where we have to look at our vasopressors, and we have to titrate our vasopressors off of that mean. If you're seeing diastolic augmentations that are huge, and your mean is big, it's large, you have a high number, our chemical balloon is working against our mechanical balloon. So that's where you start having to look at what medications do we have going. Is this patient maxed out on Levophed? Is this patient maxed out on neosynephrine? Do they have any inotropy applied? Maybe a medication that has some ability to reduce that systemic vascular resistance would go a long way in helping the mechanical balloon. So maybe titrating off some of these alpha medications, adding a medication like dobutamine or milurone. Or what if I even said, hey, let's not go that route yet. Let's maybe try some nitro. Because with any cardiac medication, you're going to have some potential side effects. Obviously, dopamine is one of those medications that we know, has a higher incidence of arrhythmias. Dobutamine is primary beta 1, has some beta 2 effects. That's where the bronchodilation comes in. You have some vasodilation. Milrinone works on calcium channels. Nitro, though, is just purely, hey, we're going to dilate the preload and afterload side. You're not going to have the cardiac side effects that you would with these other medications. So nitro is a really good medication that's used in the ICU in these patients to reduce that systemic vascular resistance, to reduce that pressure that patient's left ventricle is having to contract against. And also note that nitro is excellent in these patients with pulmonary vasoconstriction, CHF. So nitro would be probably my number one medication to apply to a patient if I saw high pressures like that. Simply reducing the Levophed, reducing the neosynephrine if those were applied, would also be my number one priority. I would try to reduce those down. Now, we've talked a lot about vasopressors in multiple podcasts, and one of the things I've talked about is Levophed is always kind of number one. But when you kind of look at neosynephrine has lost favor with a lot of people in sepsis, in neurogenic shock, but neosynephrine is still used very widely, and it's a very good medication in these cardiac patients because it stimulates aortic root pressure. It actually increases coronary artery perfusion, and so obviously that is a good thing. That's what we're kind of trying to do with that diastolic augmentation, is we're trying to increase that perfusion of the coronary arteries, increase that pressure at the aortic root. So neosynephrine would be a great medication. I would definitely want to keep that medication on. I would just watch my dosing, make sure that I'm not getting too much squeeze. If we did decide to move to a dobutamine or milrinone, if we review those two medications, we have to remember that dobutamine, again, is that beta 1, has some beta 2 stimulation effects. Again, has a lot lower incidence of arrhythmias than dopamine. Always make sure you fill the tank. Even though they may have some CHF, they may be overloaded, that doesn't mean they're not intravascularly dry. So, give them a little fluid, 250 mils at a time. But dobutamine is going to be another medication that will act on reducing that systemic vascular resistance and help you in these patients. What about milrinone? Milrinone is not a common medication that we see. I think it's used more in certain areas of the country based on all my travels. But no, milrinone is what's called a phosphodiesterase inhibitor, works directly on intracellular calcium, which we know intracellular calcium works on myocardial contractility, works on your vascular tone, and overall positive inotropy. So we have to, though, understand that if we stimulate these calcium channels, we're going to increase O2 consumption. And that's where I said maybe starting with nitro would be a better option. You have that lower incidence of cardiac effects by going that route. So our goal is going to be to titrate our vasopressors, titrate our inotropes off of our mean. Well, what mean do we shoot for? Well, it's no different, right? A MAP blood pressure for any patient should be at least 65. If we're getting 65, 70, 75, that's great. That's what we should be shooting for. So we're going to titrate our medications off of that mean, and we're going to use the same goals that we would use for any other patient. If you can hit 70, 75, 80, that's great. You don't want to be lower than 65. We know that's where we start having a big drop in renal perfusion. That's where your kidneys shut off urine output. And we know we have to have urine output, right? We have to have urine output to kind of evaluate perfusion. So we want to make sure we're above that 65 range. Remember that we are not going to get any of these pressures. When we initially set our balloon pump up and get it started, we have to re-zero our monitor. Now, whether you're using a balloon pump that has that fiber optic balloon where you're not having to actually transduce for the balloon pump, we still want to re-zero, and we're going to utilize that and evaluate that and monitor that art line. So regardless if you have a fiber optic balloon, you're still going to always re-zero that pressure bag, re-zero that transducer. So re-zeroing, that's where we're going to get our unassisted versus assisted pressures. Remember, you're going to have to be in a 1 to 2 timing to evaluate unassisted versus assisted pressures. So make sure you switch from 1 to 1 to 1 to 2 to evaluate that. Print yourself a strip. That way you have all that documented. What about fast flushing? So after we re-zero, you're always going to do a fast flush. And really ICU-wise, fast flushing happens usually every hour. But we have to remember that that catheter is really long. So we want to fast flush for, 10, 12, 15 seconds. Think about, are you flowing enough fluid through that entire catheter? And all you're doing is you're making sure you don't have any clot formations. So you're going to do a really good long fast flush. Make sure your line is completely patent and clear. And again, you just need to do that every hour. So in most cases, one time in a transport, unless you're in a fixed wing environment where you're transporting longer than an hour, one time is going to be absolutely perfect. Okay, well, that's all I have for this. I just wanted to touch on the differences between mechanical and chemical balloon. Don't let your chemical balloon inhibit your mechanical balloon. That balloon pump will do phenomenal things, but we can have medications that will inhibit that. If our medications are working too well, we have these huge augmentation pressures, huge mean pressures, and that's counterproductive. So we have to know to titrate those things off, and we have to remember it's all right to do that. That's better for your patient. If you have any questions on balloon pump therapy, please reach out to me. If I can't answer the question, I will definitely forward any questions to my good friend Kelly Miller. And until next time, we will talk to you soon.